Sorry, just give me a few minutes. Just taking a minute to go live.
Let me know when you do, and I'll
Yeah, I will.
start.
I think you're good to go.
All right. Well, welcome. Today is Saturday, October 7th, 2023, and it is Ostomy Awareness Day. This is a global event where today we celebrate ostomates and all the years and experiences and lives that we get to rejoice together, because ostomies are lifesavers. We have a special edition and a special panel of guests today on today's South Asian IBD Alliance's program and Facebook programming. I want to introduce myself, Dr. Neil Nandi. I'm an IBD specialist based here in Philadelphia. And then we have a wonderful guest panel of colorectal surgeon and two patient advocates. I'll have them go ahead and introduce themselves. We'll start with Dr. Amandeep Singh.
Yes. Thank you, Neil, for your invitation. So myself, Dr. Amandeep Singh, I'm a colorectal surgeon at Medanta, the Medicity, Delhi, India. So basically, we have a team. We are looking after the colorectal work, both malignancy and IBD. I think it's great to be here. I had a discussion with you, so I think you're doing a very good job.
Thank you very much. And Dr. Singh is very humble, but he is the director, as he mentioned, and has really helped pioneer, along with Dr. Sumit Bhatia, one of our board members, a beautiful IBD program that is very patient-centric and patient-focused at Medanta. So thank you for all the work that you've done. We also have Omma Ahmed from the UK. Omma.
Thank you, Neil. So hi, my name's Omma Ahmed. As mentioned, I'm residing in London, and I have had Crohn's disease for about 12 years now. So my aim for my Instagram page is to just raise awareness both for Crohn's disease and ostomies, especially within the South Asian and Muslim communities. So I have a Pakistani Kashmiri background, so it just sort of lends to personal experience and just helping people feel more confident in tackling any issues they have with their Crohn's and especially their ostomies, and just giving them some confidence.
Thank you, Omma, for joining us. We're really excited to have you and listen to your experience to share with our patients. We also have Kishore Pardasani, who is a very interesting and innovative individual. Kishore?
Thank you, Dr. Nandi. Thanks, everyone, for inviting me to participate on this panel. I'm Kishore Pardasani. I'm based out of Florida here in the US. I'm a sales executive. And first and foremost, I'm a son, a brother, a husband, a dad, and a friend, right? So that goes foremost in everything that I do. I've had ulcerative colitis now for about 20 plus years and been an ostomate for 15 years now. And I'm also the inventor of the OstoBuddy app that helps ostomy patients globally. So looking forward to the conversation today and discussing more about the innovations.
Thank you, Kishore. We really want to learn more about your personal story and all the hats that indeed you and each of us wear, and really interested to learn more about OstoBuddy and how it can help more ostomates around the world. So first off, let's just get level the playing field. Some of you tuning in, if you have questions, please go ahead and put them into the Facebook live stream chat. We have wonderful volunteers who are monitoring that chat box, and we'll be going ahead and having a Q&A at the end of our session. We have some questions that are queued up, but we want to level the educational field first off. And I'll ask Dr. Singh, what is an ostomy? Are there different types of ostomies? Why don't we just start with that question first? What is an ostomy and why do we do ostomies? Big question.
Yes. So Neil, ostomy is basically anastomosis which of an intestine to the skin. So basically we are joining the small or the large intestine to the skin. So the reason being, there may be multiple reasons. It can be IBD, it can be cancer. So where like we have opened the intestine, it is very dilated. If we are not able to join, so if the chances of leakage are high, in those cases, we will bring that intestine out, we'll suture it to the skin so that we can drain it with a bag, which we call as ostomy bags, or in some other circumstances where like you have a perianal Crohn disease, you have perianal fistulas, or if you have a cancer of the lower rectum. So all these cases, when you join the intestine, there are chances of leakage. So in those cases, basically it's an intentionally made opening of the small intestine onto the abdominal wall. So that is what we call as an ostomy. So depending on type, basically it can be divided based on what intestine it is. It can be a small intestine, which we call as a ileostomy. It can be a large intestine, which we call as a colostomy. So depending on which type of the intestine is there, like it may be a transverse colostomy. If the transverse part of colon is out, it can be a descending colostomy, sigmoid colostomy, based on the part of the colon which we bring it onto the abdominal wall. So based on whether it can be a end colostomy or an endoleostomy, or it can be a loop also. So our intestine is like pipes. So if you bring the pipe outside and join it to the skin, we call it as a loop ileostomy. So loop ileostomy, you will have two ends. One is a proximal, from where the stool is coming out. The other will be the distal, which will be just at the level of the skin. The other is the endoleostomy. In endoleostomy, what we do, we close the distal part and just bring the proximal part out. So technically, endoleostomy is much easier to manage compared to a loop ileostomy, because endoleostomy, the pout is above the skin level. So based on type, it can be a ileostomy or colostomy. Based on the segment, it can be a transverse colostomy, sigmoid colostomy, descending colostomy. And based on if it is a loop ileostomy, or it can be an endoleostomy. Or very rarely, we call it as a loop end colostomy. So loop end is basically sometime in obese patient, like in US, you must have seen patient where the abdominal wall is very thick. So in those cases, bringing the mesentery out is very difficult. So what we do is we bring the loop of the colostomy outside and close the distal end. So we call that as a loop end colostomy. And the last one is the Hartmann procedure. In Hartmann procedure, what you do is you divide the both the ends of the intestine. You bury the distal end inside only, leave it inside, and you bring the proximal end out. So we call that as a Hartmann procedure. So these are broadly the different kind of ileostomies and colostomies which we do routinely.
Thank you, Dr. Singh. That was really good for a hard subject for people who are very new to the subject to understand. I like to repeat things, so we always emphasize our learning points from our professors. For those of you tuning in, ostomies, there's different types of ostomies. Dr. Singh just kind of went through the anatomy. If the small intestine is routed to the skin, it's often an ileostomy. If the colon is routed to the skin, it's often a colostomy. Those are the two major types of ostomies. Oftentimes there's different nuances there. Some may have one end, and that's just an ostomy. Some may have two openings, one that goes up towards the mouth, one that goes down towards the colon direction, and those are called loops. There's even one more type of ostomy that we don't talk often as much. It's called a urostomy, and that's where that's less common to do in IBD, but some patients do have them, and that is where the bladder urine collection ducts are actually drained into a bag for urine collection. So we're going to get to our patients in just a bit, but Dr. Singh, you know, we have Crohn's and ulcerative colitis. That's the main focus of the patients that we serve here on SAIA and that you and I treat. What are some of the scenarios where patients might benefit from an ostomy? Oftentimes, I see, sometimes ostomy is presented as a last option, right? Or a failure of all treatments. But I don't know if that's the right way to think about an ostomy. I think sometimes it's a treatment option. What are the clinical scenarios you see in Crohn's or ulcerative colitis where an ostomy might be a right option for a patient?
Okay, so basically ulcerative colitis, Crohn's disease, as you know, they're entirely different disease. In ulcerative colitis, it's only involvement of the rectum going on to the different segment of the colon. So basically in ulcerative colitis, if you remove the colon surgically, make a J pouch and do a temporary ileostomy, you can actually cure the disease. Cure means you can have a good control of the disease. So in ulcerative colitis, even when the disease is medically intractable, what we call as a medical intractability. So there are different kind of indication of surgery. One is emergency. Emergency is if patient comes with a bleeding patient come with toxic megacolon. So those are, or a perforation. So those are the emergency indication for surgery. Emergency surgery invariably will need a ileostomy, because in those cases what we do is we remove the 80% of the colon. We call it as a subtotal colectomy. We close the rectum and take the ileostomy, take the part of the small intestine out as an end ileostomy. So then at the second stage, we remove that part of the rectum, make a pouch there. If a patient is fit, in elderly patient, you might just do a proctocolectomy and do an end ileostomy. So that is related to the ulcerative colitis in emergency setting. In elective settings, patient who are not tolerating the immunosuppression or the medical treatment, who are resistant to medical treatment, those who have side effects of medical treatment, or those patients who develop malignancy, or very rarely extra intestinal manifestation, or in children, it's growth retardation. So I'm not going into the detail because I think that will be more like a medical part. But yes, in emergency, you might need surgery, where you will almost always need a stoma. In elective situation, we usually remove the ulcer at the colon. If the patient is stable, we do it in a 2-stage only. We remove the colon, make a pouch, J pouch, do a temporary ileostomy. After 2 months, we just do a dye test and then close the stoma. So that is in ulcerative colitis. For Crohn's disease can affect any part of the intestine. So doing a surgery actually is not curative. So doing surgery is basically to take care of complications. So there can be a different kind of Crohn's disease. It can be a stricturing disease. It can be a fistulizing disease. So in stricturing disease, patient in obstruction, so whatever medicine you give, it's not going to work. So those are the patient who will need surgery. Whether they need stoma, I think even in majority of those patients, if the intestine is not that much dilated, patients are referred early. So those are the cases where we can just remove that segment and rejoin the small intestine. So the other part is fistulizing disease. Patient who have a fistula with the bladder, fistulas with the vagina, or those patients with the perianal Crohn disease. So these are the patients which will ultimately need a proctectomy and might need an end ileostomy. So these are more or less the indications for surgery, both in ulcerative colitis and Crohn's disease. But if basically, like I told earlier, these disease IBD, they should be managed in a multidisciplinary setting. The problem in our setting routinely is the gastroenterologists, they keep on giving all kind of drug because patient is always afraid of surgery. So I think these are the patients, these are the diseases like in acute pancreatitis, IBD. So these are the patients who should be managed from the start only by a team of doctors, including the surgeon. So they should have a background they should have in mind that what are the surgical options also available, so that it's an informed decision between the patient and surgeon and the gastroenterologist. So I think I wanted to point out that.
I think that was really good. I think you kind of pointed out, like you separated ulcerative colitis from Crohn's, and each have their unique circumstances by which they may require, a patient may benefit from an ostomy. Like you said, in ulcerative colitis, the colon may be so severely inflamed, they may not be responding to drug therapy. They may get toxic megacolon where the colon becomes very dilated or threatens to perforate. So rather than let that happen, or if it does happen, a colectomy is needed with an ostomy. One thing you pointed out was that oftentimes, and you see, if we think it's going to help the patient, we can reverse the ostomy and form a J pouch. And then in Crohn's, you mentioned 2 sets of scenarios where you have a blockage, a stricture, narrowing of the intestine that can also lead to perforation or other complications. Sometimes a gastroenterologist can open it up or dilate it if it's a short, narrow stricture, but if not, then resection is needed. And if the patient has been very malnourished, we need to do an ostomy in that setting. But the fistula, I think perianal fistulizing disease data have shown that in South Asian patients, there's an increasing prevalence of perianal fistulizing Crohn's, which can be very devastating to anyone. And oftentimes when we divert the stool into an ostomy bag, the fistulae heal. If we reconnect, the fistulae often recur. So something about the stool stream can stimulate a fistula in developing, and that's where medical therapy comes in. Sometimes we can put patients on biologic therapy or advanced immunosuppressive therapies, and we can reconnect, and in some cases they will not recur, but they generally, in my experience, need something if they're going to be reconnected. So now that we've heard, Dr. Singh, from you a little bit about what are ostomies, who gets them, what are the clinical scenarios for ulcerative colitis or Crohn's, let's turn to our patients, right? We can really learn a lot from our patients. Let me start with Omma. Omma, let me ask you, with your experience as a lived patient with IBD and colitis, when was ostomy surgery offered to you? Was it offered early, late? You know, what were your concerns about hearing about surgery to begin with?
So my circumstances were quite different, but sort of what Dr. Amandeep sort of mentioned, and that was emergency surgery. So I was diagnosed and within less than a year, my bowel perforated after I underwent an examination under anesthetic just to have a look at the bowel, and that caused a perforation. So I was kept nil by mouth for a few days. They weren't really sure what was going on. They were doing scans, but essentially they realized that there was air in the bowel and that was coming from the leak, and they needed to do emergency surgery. So I remember that that was the first time I'd ever heard of a stoma, and I had a IBD nurse come to visit me, and she asked me where would I like my stoma placed, and I was really confused. I didn't know what she was talking about. And then just the mention of like, you'll have a stoma on your stomach and you'll have a bag and that will collect your stool, it just felt so scary that I just rejected all of her information. And I just said, I don't want to talk about this. I don't want to have a stoma, because I was told that there's a chance I may not need one. So I was just adamant that I don't want a stoma. I don't want a stoma, because I had no knowledge of it at all. And it was given to me in such difficult circumstances. But essentially I did end up needing to have emergency surgery, and I was given a colostomy because the distal end of my colon is what perforated. But unfortunately, I had a lot of complications because my colon had been leaking for so many days. So they tried to wash me out and try and clean it up, but that caused like an infection, and my scarring sort of, my wound fell apart. I had to undergo like secondary healing. So that was actually the first time I'd heard of a stoma. So it was really difficult circumstances for me. I didn't really have any options with that respect, but I guess I had more of an option when it came to my proctectomy. So that was surgery that I had many years later, because in the lead up to that surgery, I was told that there's a chance that I could have a reversal. But as you mentioned, I had complications such as the RV fistula, I had perianal disease as well. So I had so many complications that essentially I was told that I'd kind of run out of medical options because my biologics weren't working. And I essentially had to have a proctectomy and make my my stoma permanent. Again, like I tried to go to another doctor, get a secondary opinion, and everyone sort of came back with the same. And once I'd had that surgery, and I had obviously the pressure from family as well, where again, they have very little understanding. A lot of my extended family live in Kashmir. So when they knew I was in hospital, but my parents couldn't really explain to them what my condition was, because they didn't really have the words, or they didn't know how to explain this kind of disease. So there was that sort of pressure as well to not have the proctectomy, with the hope that I could have a reversal and be normal again. But once I had my surgery, because a lot of my disease was in the sort of lower end of my bowel, and then also around the perianal area, I felt immediately better. Like in the lead up to surgery, I was practically bedbound. I had constant temperatures. I wasn't able to eat. I was malnourished. I literally had no semblance of like a life. But once I'd had that surgery, immediately I felt so much better. And I remember my mum even saying to me that if I knew that this would be the outcome, I would have told you to have this surgery so much sooner, because, you know, you're just physically, you look so much better. You've got so much energy and you've kind of regained your sense of self. So I think that that's kind of one of the things that I try to advocate for. And I think at the moment, like the alliance, the South Asian IBD Alliance, is sort of pushing this message of ostomy is not a last resort. And I think that's really important to have those conversations, because unfortunately, even in the medical field, it is sort of posed to you as a last resort. You try to go through all the medical options first before they offer surgery, because, and I think the way that they word it as well, it's kind of seen as like, you know, I understand it's a big change, but for a lot of people, if they were offered this surgery earlier, it would allow them to heal. If they had perianal issues, it would allow them to get over these kinds of issues and maybe be reconnected in the future. Or maybe, I think I know of somebody who has had surgery, but they haven't had a proctectomy, and they're choosing to not ever reverse their stoma, even though they're now in remission and they're nice and healthy, because they prefer having a stoma. So I think all of these stories are really important to sort of discuss and bring awareness to, because, you know, we don't want people to feel isolated, especially within the South Asian community, when there's so much stigma about, like, you know, stomas, scarring, you know, the potential of, you know, future relationships, getting married, all of these things. So yeah.
You know, I'm just listening to you and marveling that, and I say this all the time, I observe this all the time, that if we were just walking down past the street saying a casual hello, we would have no idea, you know, how strong and how much of a IBD warrior you are, what you've gone through, right? Nobody would have any idea of the suffering you went through. You said so many things in there that I think are really important for more patients to hear, and more clinicians to hear too, about making sure that ostomy is not necessarily a last resort. And ostomy, being offered ostomy surgery or offering it as a doc, is not saying that you've given up, you know, or that you know, sometimes it's the right thing to do to help a patient get back on track and live their life rather than losing time, right? Rather than losing time to be productive. Can I ask you a few questions though about your experience? You mentioned that this was emergent acute, right? You went in for a colonoscopy. It is rare to have a perforation during a procedure, but it may speak to how significantly inflamed the bowel was, but it happened. And so prior to that, it doesn't sound like, you know, anybody had talked to you about what an ostomy was or a possibility. Is that right?
Yeah, that's right. So I was in my final year of university when I started showing symptoms of Crohn's disease. But again, like, it takes a few months to get a diagnosis. So I was referred to a gastroenterologist. Again, they weren't really sure what condition I had, but after doing a colonoscopy and taking a sample, they still sort of mentioned that we're not really sure, but because of some of the symptoms you're showing, we're going to assume that it's Crohn's disease. And I think a lot of, like, we won't go into too much about it, but, you know, a lot of things can affect your condition. And for me, because I was in my final year and I was doing my master's, stress was one of the main triggers for me. So my condition essentially progressively got a lot worse. But at the time when I had my colonoscopy and I was given my diagnosis, I just had very light inflammation. It wasn't something that they were too worried about. So I was just given medication. I think I was actually given antibiotics. I think it was ciprofloxacin. So I was given antibiotics initially to try and help soothe things. And then within a year, when they did the colonoscopy a second time, and this was after I'd had an admission into hospital as well, they found I had deep ulcers. So it progressed very quickly from light inflammation to deep ulcers, which is what caused the perforation. So I think within that period, where I was seeing a gastroenterologist, colostomy or surgery was never mentioned. It was never, I think they just sort of started off with giving antibiotics, and then they progressed to giving me, I can't remember the name, but again, anti-inflammatory tablets. And then even when I sort of was admitted into hospital because I'd lost a lot of blood from the bowels and stuff, again, surgery was never mentioned. It was always like I was given steroids at that point to try and manage. So it was always medication that was the first resort. So it was a real shame that surgery was never mentioned, even as a potential, because I feel like I'm the sort of person who likes to have all of my options, even if it's what's considered like worst case scenario options. I want to know all the complications that can happen, because I like to make a really informed choice. And I think maybe it's partly because I have a science background and I have an interest in science and medicine and things, that I like to know everything, so I can take control of my situation in terms of asking the right questions, getting as much information to make an informed decision. But again, it was never mentioned. So when I was presented with this at a time where I'm in severe pain because my colon has perforated, I'm on intense pain medication, I'm not really in a right state of mind. And then that's when I'm being presented with this option of having a bag on my stomach to collect my stool. It was really difficult because automatically you think like people will be able to see it. How big is this bag? You know, it's going to be really obvious. How will I manage? Is it going to smell? You know, all of these things, because you just have no idea what an ostomy is. So that was the sort of really difficult part in being told about stomas for the first time.
Thank you, Omma. I think you brought up a lot of important points. I think some of the learning points are that when they come and meet you, Dr. Singh, they know they're talking about surgery, is on the table. But when they come and meet me in the hospital or in the clinic as a medical IBD specialist, I think I try, and we can all do better about bringing up surgery as an option. And even if it's not the first option or the second or third in the beginning for a patient who's new to the diagnosis of Crohn's or ulcerative colitis, I think it's important that we do talk about surgery, just like Omma said, because you need to get the patient prepped and ready that is a possibility. And also because we can't make that decision for the patient for surgery. We might recommend it, but we need to inform them. That was a key word that Omma said, like be informed, share decision-making, that surgery might be an option. Our medications, our advanced immunosuppressants, there's biologics and small molecules, they have anywhere ranging from a 55 to 70% efficacy, depending on the study you read, which means there's a balance of 30 to 45% at least non-response. And so if you cut it down the line, flip of the coin, that we need to be sure that when medications are not responding for our patients and their quality of life might be deteriorating, they're losing time, the prime of their lives, we need to offer surgery early and not think as a clinician that we're failing the patient. That's the worst mistake as a clinician you can have, and not present it to the patient that this is a failure of treatment. Maybe the treatment didn't respond, but maybe we're running out of time to try more treatments, because in the meantime, as Omma said, you might have ongoing inflammation that's worsening, and that might have been time that you might have diverted the intestine, allowed healing to occur, let the patient heal, become more well-nourished, maybe try another treatment later, or as new treatments are exploding onto the field of IBD, a new treatment down the line. So it's never an easy decision, but the right thing to do is offer surgery early, just as an option, just as an educational option, and then come back to that as, is this the time, by measuring, asking the patient about their quality of life and what they're prepared to do, showing ostomy in a positive light, not a negative light. Okay.
That is absolutely correct, because as she said, we have many patients whom we do a temporary stoma, but they are actually reluctant on closing that because they see the difference in quality of life before and after surgery. So like in ulcerative colitis, we have few patients whom we offer them that stomach closure after 2 months or so, but they never come for that. They are saying we are very happy with the bag because they gain weight, they have a good appetite. So we actually have to convince them that they should try closer, because we have actually made a J pouch there. So that is kind of acceptance by the patient once they see that it's actually beneficial for them. So like you rightly said, even if surgery has not to be offered, it's always better to keep a surgeon in loop, so that like in case of an emergency, like in her case, it should not like a bolt from the blue. So it should be that she's also knows what are the surgical aspect of the disease, so that she's able to understand in a short time in case of emergency. You're muted.
I'm sorry, I'm muted. I said, I'm so happy that you said that, Dr. Singh, about getting surgery involved early if it is to be a possible option, well before surgery has to be done. Obviously, Omma, you had a very emergent circumstance, but if we could go back in time, maybe having surgery involved early, just so the patient gets to know the surgeon gets to know the patient, and also the surgeon, I have a saying, a good surgeon never wants to do surgery, but the surgeon can at least outline to the patient, you may not be sick enough yet for surgery, but here's what I would be looking for. Now that you know this, you go partner with your medical IBD specialist. And if you feel like you're not going down that line, at least now you are armed with the information of when I, as a surgeon, might help with this and intervene. Let me change gears and get Kishore's perspective. Kishore, you had ulcerative colitis for 20 plus years, I think you said. And can you tell us a little bit about your journey in those 20 years with UC and medicines and how stoma surgery was offered to you?
Yeah, it's incredible hearing all of these stories. And Omma, I will say, you made a comment that resonated with me. You said, going back to being normal. What is normal in today's day and age, right? Like, normal to me, especially as I get older and I get wiser, hopefully, means, having your health, having your mental health, your physical health, so that you can care for your loved ones and for yourself as you progress. But my journey was extremely different to yours, Omma. But it's along the lines of what we're discussing today. When I was in in college, I was diagnosed with ulcerative colitis. Again, it took months for the GI specialist to give me the diagnosis, and then I went on a very healthy diet of medications, right? So you think of the immunosuppressants, you think of the prednisones, and over the course of 9 to 10 years, I became drug resistant. And I had progressed to trying Humira and Remicade, and they weren't working either. I do remember in 2009, I think, yeah, it's 2009, I was at the doctor's office, and my wife had just gotten pregnant, and I was having a realistic come to Jesus meeting. I hope I'm allowed to say that, but come to Jesus meeting with the GI doctor. And I said, I am 35 pounds underweight. I am trying every medication under the sun. What is next for me? And that's when the option of surgery had been presented to me. And I had researched surgery. We are, we do our own education on what our options are. But hearing this option from the GI was, it was shocking, right? Because now it became real that this was definitely an option. The option that was discussed with me was, we will try a J-pouch surgery. You will have a temporary ostomy to help that J-pouch heal, but you will have a total colectomy. And to me, I was younger. I was ready to try anything at this point, because I was rushing to the bathroom almost 20 to 25 times a day with bloody stool, and no medications were working. So I opted for it because they said, you are on the verge of perforation. Your disease is very advanced. You're drug resistant. And if you want to live a healthy, happy life with your daughter that is going to be born here in 9 months, then now is the time to do the surgery. So I opted for the J-pouch surgery, the 2 or 3 step surgery at that point. And I immediately remember coming out of the surgery, and I had the bag on me, and they had created the J-pouch. And I said, oh wow, this is actually happening. But that wasn't the end. It actually got worse. So for me, the J-pouch failed on me. So when I had the reversal for the J-pouch, I immediately remembered what Dr. Ahmed said, which was, I felt better when I had the ostomy. And now that I have the J-pouch connected, it's actually worse. I had bouts of pouchitis. I was back to rushing to the bathroom. And literally 4 months after having my J-pouch connected, I said, no more. I'm done with this. Give me an endoleostomy. So I dictated what the next step for me was. Now, from a cultural perspective, I think everybody understands, from a cultural perspective, it was very difficult to make that decision. Up till today, I still have my J-pouch inside of me, but I have an endoleostomy. And I will say, over the course of the past 14 to 15 years, it has given me my life back. I have traveled the world. I have a successful career. I'm present for my wife and kids and my mom every single day. And more than that, I've regained the weight, maybe more than I want to, but I've regained the weight that I had lost over the course of those years. What I want to warn, just like tell the viewers here is it's never easy. There's no silver bullet to finding the solution here. Is the ostomy going to save your life? Absolutely. For me, it did, right? For many patients, you will hear them say, it saved my life. It gave me back my life. And that's what I'm here for. Right? I'm a patient advocate just for that reason, is to help patients, other potential ostomates out there, understand that there are other options out there. And, there's no one knows whether you have an ostomy or not.
I'm just listening in awe of both of your stories. And, it's such a beautiful thing. Going through a stoma surgery is, to say the least, scary, emotional, a lot of uncertainty and angst. But to hear you both come through it and talk about how it has given your life back, given you control over the disease rather than the disease over you, I think that's one of the most empowering things I have heard. And I love to hear that. And it's thanks to the skilled hands of surgeons like Dr. Singh, who take the care to do high quality, jobs, high skill level surgery to give patients their lives back when they create these stomas and surgeries. Let me ask you, we have so many different facets that we can talk about when it comes to ostomy on our quality of life. Both of you have mentioned cultural aspects of it, stigma, and that's something we want to destigmatize here at South Asian IBD Alliance and IBD ACEs through these programming, that stomas are lifesavers, and that we are accepting of them because they allow people to be themselves and lead their lives. Let me ask you a very specific question, since we can't tackle all subjects, which is relationships, right? Both of you have mentioned relationships in different capacities, both romantic or as a brother or as a father. Can you both maybe perhaps tell us about how you managed having a stoma and having a relationship?
I guess I'll go first since I'm unmuted, but it's, there's an age-old saying, right, that through tough times, you grow closer. And I'm grateful, and I'm, just glad to have a partner in my life that has been with me through the tough times, because through the tough times, you grow closer. For me, I got married prior to having an ostomy. My wife knew that I had ulcerative colitis, and that I have, I continue to struggle with the disease and, the medications and whatnot. Many hospitalizations in between getting married and actually having an ostomy, and then making the decision to have an ostomy. While it is ultimately my decision to have an ostomy, it is our decision to have an ostomy, because having the support in your life is extremely important, because it's not going to be I'm just going to have a surgery and then I'm going to come home and everything's going to be okay. It's a journey. It's a journey not only for yourself, but it's a journey for the entire family. So having that support mechanism in the home to keep the positive vibes around you is extremely important. But to broaden the scope a little bit more, having the support system in your entire family, when it comes to your moms and your uncles and everybody else, it comes down to education. It comes down to helping them understand, look, you may not be aware that this exists. You don't know that it exists because not many people talk about it, but it is close enough to us in our family where you should learn about the impacts of this on me and to accept me for it, right? And once we got through that barrier in our family, things got way easier. Everybody started to understand, wow, Kishore is going through a lot in life. We need to support him through this journey. So I think ultimately it comes down to communication. That's all it is. It comes down to communication, and it's a bilateral communication of, here's what I need from you, and then them communicating to me that they understand that they need to support me moving forward.
That's
Omma,
very good.
what was your experience?
So my experience is slightly different because I've only been married for 3 years now. So I had already had my stoma and even my proctectomy before meeting my partner. But initially, me and him were friends for quite a long time. And again, I'd already had my stoma by the time that we met at work and we were friends. And we sort of stayed in touch over the years. But just before sort of getting into a relationship and getting married, I remember sort of speaking to him where we decided that we like each other and we would like to get married. And then I had a conversation with him and said, like, I know that you know about my stoma bag. He'd visited me with other work colleagues and friends over the years when I'd been in hospital. So he's kind of aware of it. But I had a frank conversation and I said to him that I do have a stoma bag. I do have a proctectomy, and I sort of explained that. I've got scarring because, you know, in the Muslim community, you don't have a physical relationship. So it was something that I had to explain rather than sort of visually show him. And I said, are you going to be okay with that? And he was very reassuring, like very cool about it. Like, yeah, that's fine. You know, it doesn't change who you are. And I think that was really nice to hear as well, because it's a part of who you are, but it doesn't define you completely. You still have your own sort of nuances, your personality, your likes, your dislikes, which are completely separate from just having Crohn's disease or, you know, IBD or having stoma. So that was really great. My family have always been really supportive. I come from a family of all girls. So there's 5 of us girls all together, and I'm like the second youngest. So I've always had the support of my sisters who are very like encouraging, very like, you know, I used to enjoy going to the hospital because when I was there, I just used to get takeout all the time. Everyone would come to visit me. It'd be like a little party in the hospital. It was just really nice. Whereas like normally in day-to-day life, you get sort of wrapped up in like work and other things. But those periods when I'd be in a hospital, like all of my sisters would come to visit at least every day, one by one. I'd always have company. It wasn't a time that was really traumatic for me. And it was because of the support I had. And then there's also the support of my parents. And I know it was really difficult for them because, you know, again, seeing their child in hospital, not really understanding what's going on, you know, hearing the word disabled for the first time, and, you know, that sort of having an impact on them. And for them, I think a lot of the worry was more about how other people would treat me rather than how they would see me differently. They were just always worried about sort of people treating me as a second-class citizen because, you know, I had this condition, I had this disability. They didn't want me to go through any of that sort of trauma. But I think once they sort of saw how much better I was doing, they really came on board to it. My mum always says to me that, you know, if people didn't know, they would never think there was anything wrong with you just by looking at you. And I think that that's really positive as well, because it means that you can choose who you tell. It's not something that's outwardly so obvious. So if you choose to not show that to people and not let people know, it's completely your choice. It's a personal decision. Now, getting married has been a little bit different for me because although my husband was really great and my in-laws are really great as well, I live with them. When it comes to the extended family, it's always a sort of a balance of like, who do I tell? Who do I not tell? And I've realized that I'll tell the people who are in my life often. So like his mama's family, we see them quite a lot, and it's important for them to understand because the times where I'm not feeling well, I'm sort of in bed, or the times when I have been in hospital, they know what's going on and they're really great and supportive. But then there's extended family who I don't see very often. I might see in passing, maybe at a wedding, and they don't need to know about my condition because it doesn't benefit me in any way to tell them that I have a stoma or I have Crohn's disease. So I think that it's just about your own personal choices, about who you want to inform. And as Kishore was saying, it's all about just having that support around you. So I do think it's important to tell people because you don't want this to be a burden that you're carrying by yourself. It's so much easier when you do have the support of like, whether it's your partner, your friends, your family, you know, all of them will come together and help you deal with this condition. There'll be times where you're really, really well and really active, and that's great, and you can do so much. And then there's other times where you need more support, and you will have to lean on them a little bit more and just ask them for help. And I think that that's where we have to sort of make sure that we're doing that. We're not feeling embarrassed and, you know, feeling like we have to do everything by ourselves, and asking for help when we need it.
You both are so wise. You guys have no idea how wise. I wish, you know, the beauty of recording these is I can share them with my patients, you know, as a clinician, to hear your guys' words of wisdom and how you've managed relationships, both romantic and familial. There's a couple of themes here I want to come back to. However, before I do so, I want to go back to Dr. Singh. Dr. Singh, when you see that patient and, you know, you see someone as bright and beautiful as our two patient advocates here, you're counseling them, and not just them, but their family unit, right, on the decision of whether to embark upon an ostomy. This is a huge decision for that patient, whether it be emergent or elective. What are questions that you ask as a surgeon, as a physician, to the patient and family to help them understand what's the right decision for them? What are there tips or strategies to help a patient understand whether a stoma or how a stoma will benefit them, that you ask, that you can share?
Yes, Dr. Nandi, it's, I think, a very difficult this task to convey to the patient, yes, you need a stoma. Because in India, our patients are not as wise or talented as these two people, because they can at least understand what's happening. Because we have actually patients from middle class or a lower socioeconomic status, they don't understand what stoma is. So they just do not want an opening here on the abdomen. That is their only what they can understand. If it's an educated person, you can show them the videos, you can make a diagram, show them that this is necessary. You can make them meet people or other patient who have undergone a stoma. So it's very easy to make them understand. But in patient who are illiterate, it's very difficult. They are only on one thing, that no, whatever God has given, we are happy with that. Don't change our anatomy. So those are the most difficult patient to handle. But otherwise, majority of patient, yes, they do understand. So if the surgeon is in scene from the starting, it's very easy to communicate because we both know each other. Otherwise, at the late stage, once you are in the picture, maybe in the middle of night, going in for emergency surgery, it's like patient is looking to you like you're a villain coming to make a stoma there. So that is the reason I told earlier that I think there should be a familiarity with the surgeon also from the very beginning, so that in case he is required at a later stage, patient don't take him as a negative personality. So otherwise, in a OPD, majority of time I call these patients at a time when I can give them maybe 1 hour or 2 hours at least for counseling. Because if you call these patients in a routine OPD, when your 20 patients are waiting outside, it's very difficult to, because you are also preoccupied in your mind. So I call them at on my free day, maybe a Saturday when I don't have a routine OT day. So you have to spend time with them. It's not only the counseling of the patient, it's counseling of the family also, to make them understand, because for patient, he is suffering. So he will anyway understand, because even after maybe 2 months, 3 months, when he gains weight, he gets his appetite back, patient will be very happy. The main problem will be with the attendant, with the family, because they see that yes, he is improving, but for them it's like a burden which will continue throughout the life. And also for their employers. So patient is doing some kind of a work, so they think it's kind of it's a handicap. So he cannot do that kind of traveling. So they have to adjust them. So I think it's a counseling not only of the patient, of the family also, and if possible of the employer also. So for doing that, you should have a kind of a counselor in your hospital who can counsel the family. The best counselor though is the doctor who is in familiarity with the patient. And moreover, these kind of the community nurses, so you can make them aware of what kind of stoma is. Like we have a stoma care clinic in our hospital. So it's kind of a center of excellence for stoma care, which we have made. So there are different kind of videos, what stoma is. We have a lot of literature. We give them booklets. We give them links to the YouTube videos where they can understand what exactly a stoma is, what their body is going to be like after the stoma preparation. So if you do all kind of educational counseling, it's the patient majority of time understand what's happening and they will be ready for a stoma. In an emergency scenario is different because you don't have a choice. So you have to go ahead and do the stoma.
I think, I'm so happy to hear that you take the time out on your weekend to make extra time to call the family. I think no surprise, you go above and beyond, Dr. Singh, to help your patients and make that decision. There's a lot of common themes. I'm going to come back and summarize in just a bit. As we get close to our hour, I would like, Kishore, if you don't mind, can you tell us a little bit more about your creation, OstoBuddy?
Thank you. Yeah, but before I get to that, I just want to make a comment to Dr. Amandeep. If your patients are asking you the benefit of an ostomy, just tell them it's a superpower. Because before you get an ostomy, like you go to a restaurant or you go somewhere, what are we looking for, Omma? We're looking for the bathrooms. Where's the closest bathroom, right? You don't have to do that anymore. And it's before, like you don't realize it, but it's a superpower because you can go travel the world, you can go do anything you want, and you don't have this constant thing in your head, in the back of your mind of, I need to know where the bathroom is, right? So Dr. Amandeep, I would be glad to talk to your future patients about this as well.
Yes, that is very true. The same coming from my mouth, they don't understand. They think he's a surgeon, he's just going to do the surgery. So if the same comes from a person, so we have a basically list of patients who are from all the localities. So we find a person who is ready to go to their house, or they can meet them and he can understand. But if the same person is from the same community, I think people accept that easily. So that we have a list of all our previous patients. We make them meet a person from their own community. So that matters a lot, because surgeon, I think they think that he's a surgeon, he will anyway say these things.
This is true, but we're all about breaking stereotypes, right? So we can, just like you are, Dr. Singh. Kishore, I think that was a great point. Superpower for sure. We are superheroes, IBD patients. Can you tell us a little bit, OstoBuddy? I really want our viewership to learn a little bit more about the platform you've developed, and then we'll start to wrap up here. But tell us a little bit more about OstoBuddy, which you've created.
Yeah, thank you for the opportunity for me to share a little bit more about my invention. So I'll start with the why. The why is when I got home from the hospital after getting the brand new shiny stoma, I received a plethora of supplies at my doorstep. You get a bag and a wafer and the sticky glue, and then you have the remover wipes. And what was very apparent to me was this is going to take some coordination, right? It's going to take some tracking. So the math wizard that I am, I resorted to opening an Excel spreadsheet, and I had a list of all of my supplies when I was using what, because one of the things you need to really focus on is you'd never want to end up not having any supplies on hand. That would be a really bad situation for everybody, not only yourself, but people around you, right? So the problem that I looked out to solve was, okay, there has to be a much better way of helping ostomy patients track supplies. Very simple concept. I went on the App Store and the Play Store, and I looked for ostomy apps. Nothing existed. And it blew my mind. Like, nobody was focusing on helping ostomy patients just have a better quality of life, because the improvement of quality of life comes from a set it and forget it. It's similar to, all the other apps that you typically use, right? Your health and fitness apps and your to-do apps and your task managers, etc. You write it down and it reminds you when you need to do it next. So it's not constantly in the back of your mind. So therein was born OstoBuddy. So what OstoBuddy helps an ostomy patient do is it helps you input all of the different supplies that you typically use. Whenever you receive orders, you input the quantities into the OstoBuddy app. And then what you do is you actually use those supplies on a regular basis. You can keep track of a picture of your stoma and your peristoma area. Why that's important? It's because if at any point you do get some deterioration of the peristomal skin, then you can go back to your stoma nurse or your doctor and show them, here's how my skin has progressed over the past month or 2 months. And then that helps the nurse pinpoint what potentially caused it. Was it a change in product? Was it because you took too long to change since your last wafer change? These are the types of problems this Ostomy app is trying to solve. The other area of the app is also output tracking. Believe it or not, until today, doctors are sending patients home with a piece of paper to track the output after they've had ostomy surgery. There has to be a much better way of doing it. The problem with that is because you're writing things down on a piece of paper, and then the surgeons tell you, come back to me in 2 weeks and show me that piece of paper. And the point of it is to avoid potential dehydration. Because if your output is too high, you need to be able to control it. What happened with me personally was within that 2-week period, I hadn't developed Ostobuddy yet, so I was writing this down on a piece of paper. I actually got rehospitalized. The rehospitalization rate here in the United States alone is extremely high. Rehospitalization for dehydration-related issues after ostomy surgery. So what the Ostobuddy app helps you do is actually helps you keep track of all of your output. You enter it into the app, and then there are specific thresholds and alerts where the Ostobuddy app actually helps you say, okay, your output is way too high. Maybe you need to rehydrate more, or call your surgeon and be a little bit more proactive with this potential issue that could happen. So these are just some of the solutions that are problems we're trying to solve with the Ostobuddy app. Ostobuddy is free for everybody to use globally. There's no payment for it. And in fact, I was lucky enough to connect with the SAIA organization with Tina at an IBD Innovation Challenge earlier this year, where I won the award alongside Tina and the SAIA community. So that's a little bit about the Ostobuddy app. I'm hoping that everybody that's watching this sees that there is innovation happening above and beyond just the bags themselves, but everything around it, just to help you improve your quality of life.
Thank you, Kishore. I think that what you've developed, that platform, that app is really useful. It's practical. It's going to help a lot of patients. For those of you listening, you can go to ostobuddy.com. If you're South Asian, you like free. Free is good. We love free. But you can download either version from Google App Store or Google Play Store or for iPhone. But thank you, Kishore. That took a lot of personal investment of your time and know-how. It's obviously a passion project that's being recognized by different companies, entities, the Shark Tank Innovation, by Lifebulb, BMS, and certainly by us here at SAIA. So it was really serendipitous that SAIA has gotten to make your acquaintance and bring you aboard. So thank you for being a patient advocate in every true sense of the word. And special thanks to Omma as well. Omma, thank you so much for being here and sharing your experience. And Dr. Singh, before I really give my thanks to all of you, I want to backtrack and say, I'd like to go around and see if each of you can give one, parting take-home empowering message for our South Asian IBD patients globally, for our ostomates or those pending ostomy surgery, perhaps. What would you like them to take away from this initial conversation that we're having today? Why don't I start with Dr. Singh?
Okay. Can I have two messages?
Yes, you can.
So I think first point which I wanted to stress is that in your area, wherever these patients are, you should have a support group meeting. So maybe it's kind of a district, kind of a state, because that is, I think, where the patients are more comfortable. There are many patients like of mine who are engineers. So they have devised their own innovative ideas, which they are using, but which can be used by actually a large number of patients. So probably in those support group meetings, maybe once a month, once 3 monthly, so they can share their ideas with each other. They can discuss their problems, and maybe all of them can benefit from each other experiences. The second thing I would like to highlight is, I think there is a lot to be done about the education of surgeons also apart from the patients. I know this is more like a patient forum, but the ostomy complications are related to the technical aspects of the surgery. So we do a lot of badly fashioned stomas in which there are hernias. Hernias can even happen with the good fashioned stoma, but all these complications, skin irritation, where the stoma is placed, there is a lot of science behind these things. So we spend around 1 hour, at least a day prior to the surgery, making the patient stand up, lying down, where they're actually, what kind of dressing they're using, so what kind of dresses they're wearing. So all those things have to be kept in mind before giving a stoma to a patient. So I think these are the things which are actually ignored by even majority of surgeons in India. I'm not sure about the US. So I think we should have an education about surgeons also, where to place a stoma, how to fashion a stoma, because majority of the problems which patient face are because of a poorly fashioned stoma. So we can avoid those things.
I agree with you, Dr. Singh. And yes, I can say that clinicians here in the US can also benefit greatly from ostomy education. I'm really happy to say that we have some wonderful co-chairs who lead our Advances in IBD conference and our Crohn's and Colitis Clinical Congress that are upcoming this year, where they've actually put front stage ostomy education for clinicians on different tracks. So but that's just the beginning. We need to continue to educate clinicians so they can help patients in the clinic. And also, like you said, increase access to interostomal clinics where they can have access to wound care nurses who know how to help manage, in addition to the clinician, how to manage a stoma. Omma, any parting words that you can share with our audience today?
Oh, there's so much I'd like to say to sort of patients who either have a stoma, who are thinking of getting a stoma. And I think I just want to say that you need to make the best choice for you. And I know it's difficult to not be affected by cultural ideas and stigmas, but essentially this is your life. And you're the one who is in pain when you are going through, your condition. So when it comes to getting a stoma, don't be reluctant just because you worry about what society will say. It's a personal choice. And again, one of the benefits is you can choose to hide it if you want to. Not everybody needs to know. And it will benefit you in ways that you can't even imagine. So, it really makes me sad that people avoid getting this surgery because of these stigmas, and they're just living in pain and not really living their life the way that they want to. And I think if they speak to many ostomates as well, they'll realize that it is the best option. So try and be strong, try and educate your peers, your family, your elders. And I think one of the ways to do that is to just speak about your condition and your stoma confidently. Don't see it as a negative, and don't present the idea of your stoma with any negative connotations, because people will jump on that and then also see it negatively. But present it in a positive manner, as in, it's helped me so much. I'm no longer pain free. I'm no longer running to the toilet constantly. I'm able to eat better. I can now do activities. I can go to the gym. I feel stronger in myself. I'm so much healthier than I ever was. So that's the way that you should present when you're speaking or educating people. So really just do what's best for you as an individual, rather than, within your culture and your society.
Wise words, Omma, wise words. Kishore?
Oh man, so much has been said already. How much more can I add? I'll just say this. If a guy from Florida that had ulcerative colitis, failed all medication therapy, went through a J-pod surgery, ended up with an endoleostomy, is married, has kids, and has a successful career, can do it, so can you. I mean, if it seems hard, and it's not easy. I'm not going to sugarcoat this and tell you it's easy. It's not easy. Every single aspect around the cultural aspect that Omma mentioned, the surgical aspect that Dr. Amandeep mentioned, it is not easy, but the end outcome, you're going to feel a lot better about it. So make sure you talk to a lot of other ostomates, talk to a lot of other patients that have gone through this journey to prepare yourself. that's all I would recommend.
I think that's excellent. I think the common thing I've heard from each and every one of you is about communication, clear communication with your family, with your partners, having clear talks about the decision to undergo a stoma, involving them early rather than letting the tension build of not doing it. I think something that Dr. Singh pointed out was that sometimes when it comes to that decision of the stoma, the patient, a big barrier might be the patient's perception of their family's pressure, what the family or cultural stigma might be. And that's holding them back from making a decision that will help them actually thrive and recover and get better. But each of you as patients and as a surgeon have really emphasized the point of clear communication. So we have to ask questions. It's scary to ask questions. It's scary to share. But with the people who are in your immediate family and support structure, it's always never more important to talk about it and just, take that leap of faith and have those conversations because they're going to have your back. I love the fact that all of you really showed how much more that words matter, right? Omma, you were just saying this, right? I am capable, right? I am empowered. Not about I can't do this, I can't that. I am now a superhero, right? I don't have to worry about the bathrooms. I am able to carry my life as I see fit. Like Kishore said, it is not an easy journey, but it is a journey. An ostomy can give your life back and help you realize your dreams, fulfill your wishes. And sometimes delaying that ostomy surgery is actually going to cause you more harm than good. At South Asian IBD Alliance, we're trying to pull together all sorts of partners from around the world, all sorts of different organizations that are really trying to ultimately help the end person who's most important of all. That is you, the patients. So if you come to South Asian IBD Alliance on our web pages and our social media streams, you'll find all sorts of links and resources to organizations that can help you, different facets of IBD. When it comes to ostomy surgery, there are several websites and references you can visit. In India, there's actually ostomyindia.com. There's a Crohn's and Colitis Foundation in almost every continent in India, UK, and US. There's the United Ostomy Associates of America. It's a 60-plus nonprofit. The website is ostomy.org, all free information about diet and ostomy care. There's also the WOCN, Wound and Ostomy Care Nurses Organization. At SAIA, we have a patient-focused group called IBD Desis, that's 1D, which is a Facebook community, a safe space where conversations about IBD and ostomy are discussed and moderated. And then also there's a US-based nonprofit called Girls with Guts, which is a 10-year, they just celebrated 10 years this year, nonprofit for women with IBD and ostomies. So multiple resources that we've curated just for you. And also we have other live streams that have focused on pregnancy, conception, new cutting-edge therapies. In short, we hope that this discussion today changed your mind about how to think about ostomies, who will benefit, how you might benefit, and will also open a gateway of resources that you as a family member or patient can share. I want to say thank you so much on this very special day, Ostomy Awareness Day 2023, to Omma, Kishore, and Dr. Singh. Thank you. On behalf of South Asian IBD Alliance, we are indebted.